In this first lesson, motor systems, we are going to follow the path of how neurons up in primary motor cortex send information down action potentials down the corticospinal tract to innervate second-order neurons in the spinal cord, which then leads to contraction of skeletal muscle. We covered that skeletal muscle physiology in Gen Phys. Now we're going to pay close attention to the neurons and the tracts between them. Let's start off by looking at primary motor cortex and the frontal lobe. This first figure is of the same brain, decorated in a different way. The beginning here, on the one on the left, we are looking at the lateral aspect of the left hemisphere. Eyeball, nose have been dissected away to show us just the brain. You can see the dura, that will be the cerebral falx. Frontal lobe, down here is temporal lobe, which has been reflected away to show us what's inside the sylvian fissure. The occipital lobe sort of gets cut off, and the parietal lobe over here. This is what it actually looks like. Then we go to the second, where things have been color-coded to identify where the lobes actually are. Of course, these structures are continuous with each other, but we've been able to identify functional regions, and these gyri are separated by sulci. And so we have some idea of where one lobe begins and where another ends, but those lobes are simply a human way of assigning a function to a region. The biggest one is the central sulcus that separates the frontal lobe from the parietal lobe. The precentral gyrus is motor cortex. The postcentral gyrus is going to be primary somatosensory cortex. We'll look at in the next lesson. The temporal lobe in green, and the occipital lobe in black in gray. Now, more than the frontal and parietal lobe, the parietal, temporal, and occipital lobe are far more contiguous and shared function. The frontal lobe is where primary motor cortex is, but also areas of premotor cortex that help plan the movement, and other structures that are higher evolved. Things like thought, attention, cognition, inhibition. These centers have projections all over the brain and brainstem, especially to the limbic system, coordinating behavior and reward and emotion. We're not talking about these. We only care about, in this story, the motor cortex, the final signal of all of the frontal lobe's decisions. The motor cortex projects axons down the vertebral column, down the spinal cord, in order to get skeletal muscle to move. And you'll notice also Broca's area right next to it. Broca's area is required for language. The person with a Broca's area aphasia can think about the word, can understand words without a problem. But when it comes to actually mouthing them out, they're not able to do so. That is because the area that does that is Broca's area. And as we're about to see, when connected to the homunculus, the motor neurons for the face and tongue are right next door. Right, this figure is about the homunculus. Before we get there, what I want to show you in the first two images is where motor cortex, primary motor cortex, is represented. On this first image, you've got a mid-sagittal view. This is the corpus callosum, lateral ventricle, midbrain, pons, cerebellum, medulla, stem. Come back up here. We have the superior sagittal sinus in its dura, and then a whole bunch of brain. And notice only this little smidgen is labeled in red. That is the primary motor cortex on the median side of the brain. You can notice it doesn't go down to the corpus callosum because the cingulate gyrus is under it. This wraps around onto the lateral side, which is shown in the second image. What this view is the same sagittal view, just with a narrowed focus, with the temporal lobe left in, and only the precentral gyrus and the postcentral gyrus, its fissure in between, left on. Everything else has been dissected away. The reason for that is to allow us to show you, hey, the motor cortex begins within the sylvian fissure and sort of climbs up the lateral side and wraps over to be in the medial side. You'll notice it's been labeled mouth, lips, face, hands, chest, waist, and then it's sort of topped off because leg and torso are taken care of by the median aspect. The homunculus represents the representation of neurons as corresponding to how many neurons are dedicated to the muscles in different areas. You'll notice that it does go from superior to inferior, more or less, except for the tongue. The idea is that the amount of space is taken up by a certain body part represents the sheer number of neurons represented by that, which means more neurons, more control. Speech and swallowing are pretty important things, which is why they have so many neurons dedicated to such little muscles. The hands can do very fine-tuned movements, and so in order to do that, you need more neurons. And so the torso, legs, and feet need less because there's not fine motor movements like such as writing you do with your feet. In fact, you can't because you don't have enough neurons to have such sensitive connection. So what I want you to see is the representation of superior to inferior over the side, lateral, and then down to the inferior as you get down to the median side. The more motor neurons there are, the finer the movement, the bigger the representation on cortex. That's the homunculus. This figure is designed to show you the vasculature of motor cortex. There's a lot of other stuff that these blood vessels do, but we're going to see those in a later lesson in this island. I want you to focus only on the perfusion of motor cortex. In C, it's probably the most obvious and corresponds relatively to the homunculus. You can see that the middle cerebral artery is going to take care of the majority of motor cortex. Right? So everything that was represented, tongue, lips, face, hands, arm, all taken care of by the middle cerebral artery. The anterior cerebral artery is going to take care of the legs and feet. The area in between is a watershed area shared by these two arteries. Not anastomosis, a watershed area, so the most vulnerable to hypotension. This coronal slice corresponds to that homunculus image, so you can easily map that on. But I also wanted to show it to you if you're in a lateral view. This is the frontal lobe, temporal lobe here, occipital lobe. Central sulcus, precentral gyrus. The middle cerebral artery is the majority. The anterior cerebral artery is a little bit, you can't see it, of course, because it slips around to the median side, and the watershed area is sort of nebulously formed. This is not placed very specifically. It's just to show you that there is a change from middle cerebral to anterior cerebral, and where that happens varies variable between patients. In A, you can see we're looking down and at the front of the brain over here. And so what's happened is this has been cut away. So you can see the true arteries. This is the anterior cerebral artery penetrating the sulci and hopping over the top. On the right side, this is the left side of the patient, you can see that the same idea, that there's going to be a cingulate gyrus, it doesn't get touched. Then there's an anterior cerebral artery representation of the motor cortex, middle cerebral artery representation, and a generalized watershed in between. After that tour of primary motor cortex, there are a couple things I really want you to know. First, the central sulcus separates primary motor cortex from sensory, and primary motor cortex is the precentral gyrus. That means the gray matter of the precentral gyrus is all of the neurons that are going to project axons down into the tract. We begin our story with the pyramidal neurons who have axons that will traverse the entire vertebral body, innervating second-order motor neurons to move the skeletal muscle. There's lots of other stuff that goes on in the frontal lobe. It's involved in attention, behavior, it interacts with the limbic system, and it does a whole bunch of other stuff, but I don't want you focused on this because we're talking specifically about motor tracts. In particular, there is a premotor gyrus, premotor cortex, and the basal ganglia and cerebellum. You can keep adding on all the complex interactions. This one starts you at primary motor cortex down, the emphasis on the vertebral column. This other thing we want you to know is the vasculature and topography. The homunculus showed you that more or less lateral means higher up in the body if you do this. Then it works, right? Face and hands are first. They have got the largest surface area, which means the most neurons dedicated to them, which means the finest motor control. It wraps around the medial side, where the anterior cerebral artery will take care of the median side of the precentral gyrus of motor cortex. And it also happens to correlate to the inferior portions of the body, some important for strokes. And in between, the middle cerebral artery taking care of face and hand, and the anterior cerebral artery taking care of the leg and the foot, there's a watershed area in between. That's, again, going to be important when we talk about strokes. And just to remind you, the cerebral falx separates one half from the other, and this, of course, is going to be true on the other side. So that was sort of the warm-up to get us to the tracts. All right, there is a lot to see on this. This is the corticospinal tract, the motor, the thing that comes from motor cortex down to any skeletal muscle that cortex wills to move. And so we're going to take it one step at a time. First, we're just going to follow it. Don't worry about topography, just follow the red tube, right? Because this is a tract, and all tracts are just bundles of axons of similar kinds. The signal starts in cortex, does this fan thing we'll get back to in a moment, and then travels in the first named thing in the posterior limb of the internal capsule. Posterior limb, internal capsule. It then will travel into the midbrain, where there is a cerebral peduncle, or basis pedunculi, where the corticospinal tract travels in front of the substantia nigra. As it gets down into the pons, the tracts are sometimes interrupted by the cross-linking of the axons of the cerebral peduncle. And then, when they get down into the medulla, they are the medullary pyramids. The medullary pyramids got its name because these cells up here in cortex are multipolar. They're pyramidal. At the most distal of the medulla, there's the decussation of the pyramids. That means axons cross over. Don't worry about topography, but they switch sides essentially because there's two, one from each side of cortex. And what's going to happen, and this is very important for where we're going, the side of cortex that this tract starts on will cross over and innervate neurons of the other side, the contralateral side from their origination. And it will travel in the lateral corticospinal tract until it gets to the most distal motor neuron. Now you notice that there's still some red in front, so not all of this is specifically the lateral corticospinal tract, but I'm not going to teach you at all what these are. So what I want you to see is this is truth, but we're going to follow one tract, and it's going to help us identify disease and predict radiography. Let's do this again, now using topography. Face, hand, arm, leg, foot. You can also do this, because obviously the face is going to be below the crossing of the medullas. This is actually how I learned it, and so how I'm teaching it. But you can also do it with cervical, thoracic, lumbar, sacrum. Works better. Either way, pick one. I'm going to try to do both as I go through. The first thing is to see that the most superior structure, cervical to sacral, the most superior head, hand, arm, start on the most lateral side of motor cortex. That immediately changes and will forever be the opposite as it goes through. The face becomes medial. Cervical axons, or axons destined for cervical neurons, will be in the medial aspect of the internal capsule. Medial to lateral, cervical to sacral, always will be maintained throughout the rest of this tract. It matters from when we start to define lesions of the tract, knowing where the lesion is to predict the symptoms, or knowing the symptoms to predict the lesion. Medial to lateral, superior to inferior, medial to lateral, cervical to sacral. They travel in the posterior limb, internal capsule, and they enter the medullary pyramids. They become the pyramids, the tract it does, medial to lateral, superior to inferior, medial to lateral, cervical to sacral. They cross, medial to lateral, first to last. The first to cross will be the most superior, the most cervical, the highest up. Highest up goes first. Highest up is medial. It goes from medial to medial and travels in the spinal cord, medial to lateral, in the lateral corticospinal tract. The reason for that is its position. Medial aspect of the tract, lateral aspect of the tract, anterior horn, where they need to synapse with their target motor neuron, which means that in order to get out of this thing, this bundle, they have to be medial to exit first. So the medial fibers exit first because they are the highest up. Medial to lateral, superior to inferior. Medial to lateral, cervical to sacral. They come out in order. And because they come out in synapse on motor neurons, the tract will get smaller the lower it goes. There was a lot in that. And so I'm basically going to repeat it, not necessarily verbatim, but pretty close, using my illustration on the board. There are two corticospinal tracts. The left one on the left side of the board and the right one on the right side of the board, and you do this exercise. You will have to flip it around for when you're dealing with patients, but I want you to see left, right. Don't confuse it any further. You can either do it as I learned it, which was face to feet, medial to lateral, once in the tract, or more appropriately, because the face axons have already synapsed before the medulla, but this helped me figure it out. So face to foot, medial to lateral. More accurately, cervical to sacral vertebral column, medial to lateral. The point is, the ones that are medial are going to exit the tract first. They're going to innervate higher up in the vertebral column. In the internal capsule, they establish face to foot, medial to lateral. In the internal capsule, they establish cervical to sacral, medial to lateral. They both mean the same thing, pick yours. In the medulla, they crisscross, and they crisscross in the same order. Medial to lateral, face to foot. They cross medial to lateral, cervical to sacral. So the sacral are the last to cross, and the cervical are the first. When they're in the cord, they maintain the exact same arrangement, medial to lateral, cervical to sacral, medial to lateral, face to foot. The reason why they do that is because they're getting into the lateral corticospinal tract. I'm not only going to teach you that one, and so their orientation in the spinal cord helps to define why they are that way. Because it backs up to the lateral side of the vertebral column, and the anterior horns are medial to it, they're going to establish this arrangement where they come out one at a time. And so the medial ones come out first because the next one after it can then have access to the door. I consider this the front door of the corticospinal tract. This is not how it actually is, but it helps me remember the topographic arrangement. It has to be medial to lateral, cervical to sacral, because the ones higher up have to come out first. And so here it is again, saying the same thing, but in a different way. Medial to lateral, cervical, sacral. Medial to lateral, face to foot. The doors are open to the middle where they're going to be able to get onto their sides, neurons of the anterior horn. The axons come out medially, and therefore the width, the size of the white matter decreases, the size of the cord decreases. Distal axons leave the tract to synapse on their target second order motor neuron the last. The most distal leave last, so they have to be the most lateral. The ones that are going to innervate the foot are the last to leave, so must be the most lateral in order to gain access, or everyone else have access to the front door immediately. Thus, the size and shape are going to decrease. The amount of white matter, because these are axons that are myelinated, gets smaller the further you go distally. If that wasn't pure repetition, and you've learned something from this version that you didn't get from the first one, I'd back it up and do them both again. If that was painful, you're like, yeah, I got it already? Awesome. Let's move on. Start talking about what this actually looks like, looking at different segments of the spinal cord based on their vertebral level. This figure shows us what different spinal cord segments look like. They are supposed to decrease in size, but in order to evaluate the details of each one, they've been actually sized up to match each other. But as you go down, which is left to right, as you go down the spinal cord, there's going to be less white matter, and it's the same gray matter, so the size, the circumference is going to decrease. It's going to taper. It does so very aggressively at the cona medullaris, something we'll talk about later in the spinal cord lesson. But here, I want you to see the ratio of white matter to gray matter. In the first sample, we have a cervical cord sample, stained with that same material that makes the white matter dark and the gray matter light, so stain matters. You can see how much white matter there is relative to the sacral, which has almost none. And again, on the outside of the spinal cord is where the white matter is. This is about to turn into peripheral nerves in the cona medullaris. So as we go down left to right, cervical has a lot of white matter because all of the sensory fibers would have already entered the spinal cord, and all of the motor fibers descending will not yet have left. As you move down, there's going to be a decrease in the amount of white matter in the cervical to thoracic level. Classic to the thoracic is this butterfly-looking thing with slender horns, lots of white matter. Corticospinal tract is over here. Drawing it nebulously, you can't actually see it defined by the axons. In the lumbar region, can see that the white matter has started to really give way to gray matter. This surrounding this sample is the dura mater. This is the cerebrospinal fluid space, and that is probably the arachnoid layer. This one does not have it. This one doesn't have it either. These are the peripheral nerves coming into the posterior horn, or the dorsal horn. But we're going to stay focused on the anterior horn, because that is where the motor neurons are that will be synapsed upon by the tract we just discussed, and then will leave anteriorly to enter the peripheral nerve, out to go innervate skeletal muscle. As you move left or right, less white matter, and the cord will begin to taper as it gets to the cona medullaris. All right, so we saw that as you move down the spinal cord, the cord gets smaller, and the white matter loses density. The reason for that is axons leave. Axons are the tract. The spinal cord is neurons and axons in the cells that support them. And so if there are axons leaving higher up, it means there's less axons on the way down. And so what you're going to see in the cervical region is the greatest amount of white matter and the largest size cord. And it's going to taper down to the sacral area where it turns into the cona medullaris and eventually the cauda equina, which we'll talk about in future lesson. In between, there's a shift. And so what you should be looking out for is a direct representation of the thing that I just showed you. But the cervical one is really fat. The thoracic one's got the little butterfly. The lumbar's got a whole bunch of gray matter. And the sacral, you're probably not even going to be given a sacral example because it turns into the cona medullaris and cauda equina. I don't want you learning that just yet. We're almost there. So I put in that image to represent the very bottom of the lumbral vertebral regions. Right, so now I want to talk a little bit about the reflex arc because that's how we're going to identify and lateralize lesions. To figure out whether there's an upper or a lower motor neuron lesion, you're going to rely on reflexes. And you've seen this before in Gen Phys, but I want to show you again. In this, the examiner strikes the patella tendon with the reflex hammer, or stiff fingers. What that's going to do is cause stretch of the muscle spindle of the quadriceps. That sense is carried on by sensory neurons who have their cell bodies in the dorsal root ganglion, and project its axon onto cells in the anterior horn. There's no going up to cortex. This happens at the level of the vertebra. That signal is going to send both an excitatory signal that contracts the quadriceps and through an interneuron, an inhibitory signal to the opposing muscles. If this is intact, it will behave normally. If this is intact and you lose the tract above it, there's no influence from cortex, this will be accelerated or excited. There'll be more reflex, hyperreflexia. If the lesion is at this level, it may involve the tract or not, but if you lose the motor neurons in the anterior horn, there can't be any signal out, so areflexia. That's the difference between lower and upper motor neuron lesions. That information is going to let us talk about the next thing. The next thing is what this entire lesson has been about. You assess for weakness, you find it. It's then your job to decide, is the weakness I found caused by an upper or a lower motor neuron lesion? Of course, it's peripheral nerve stuff, right? But in this lesson and in the systems we're talking about, your job is going to be define the weakness as upper or lower motor neuron. Upper means the signal is lost, but the neuron is good. The neuron in the spinal cord is good, hyperreflexia, high tone. If the motor neuron in the vertebra is the problem and the tract is good, it doesn't matter what happens to that area, there's no final signal out. Areflexia and atrophic weakness. Let's take a look at those above and below lesions. This is going to show us what it looks like to be a lower motor neuron lesion or an upper. A lesion of the tract eliminates the signal from cortex, the upper motor neuron, of getting any signal down to the vertebra. A lesion of the anterior horn is going to take the cell bodies of the neurons, the lower motor neurons, and eliminate any output to muscle. So at the level of a lesion, bomb went off. This bomb's going to take the anterior horn and the lateral corticospinal tract, which is why both have been lesioned. At the level it happens, the lesion, because below the lesion is normal, above lesion is normal, there's just interruption in the tract. At the level of the lesion, the lower motor neuron is gone. The output to skeletal muscle, eliminated. So no matter what, nothing will contract the skeletal muscle. So the muscle atrophies. And because there's no lower motor neuron, the reflex arc has nowhere to go. Even if this dorsal ganglion cell is still sensing changes, it doesn't deliver it to anything. So at the level of the lesion, there will be muscle atrophy and areflexia or hyporeflexia. Take the same patient below the lesion, which you see over here in the finder, tract is grayed out. Even though the axons are there, the signal can't come from cortex. What that means is cortex can't get the signal to move. That's weakness. You cannot will the movement of the muscle, so the muscle won't move. I'm talking extremes here, of course, because there can be partial lesions. But what we're saying is, if there's no connection from cortex to spinal cord, the patient is unable to consciously move that muscle. But because that tract also carries with it inhibitory neurons and influences interneurons, below the lesion, the reflex arc is intact. So even though the patient cannot move the muscle willingly, if the stimulus is sent around the reflex arc without any inhibition signals from above, the patient is going to present with a spastic weakness and hyperreflexia, increased tone. And just to round this out, this one depicts a lesion of the peripheral nerve so that the motor neuron never gets to muscle. That muscle atrophies, and there's hyporeflexia, just as if the bomb went off. The difference is that in a peripheral nerve lesion, the tract is maintained. So below the lesion of a peripheral nerve injury, the rest of the corticospinal tract is completely normal. Only the peripheral nerve that was severed will have a deficiency in the muscle. Above the lesion, below the lesion, at the lesion. That's what you're going to have to be able to do. Either know the lesion, predict the symptom, or find the symptom, predict the lesion. Because motor neurons cross the medulla, and what we're talking about now and for the next few lessons is only in the spinal cord, you can assume that if there is a symptom or a lesion, the opposite finding will be on the ipsilateral side. Because tracts get smaller as they go lower, and axons leave the tract above the lesion, which means that only those axons which pass through the lesion, and if you can maintain directionality, that is, the motor tracts go down, I see them as moving, those that collide with the lesion, the signal that they carry will never get to the things going to, which means two things. At the level of the lesion, the motor neurons that those axons were going to synapse on are lost. At the level of the lesion, you have a lower motor neuron symptoms. Ipsilateral hypotonic weakness, areflexia. Why? Because you lost the second order motor neuron, the final output. For all those levels below that, the axons from above will never get there, which means that there can't be a willful moving of that muscle because the signal can never get to the motor neuron. And so below the lesion is an upper motor neuron symptoms. Ipsilateral hypertonic weakness with hyperreflexia. The reason for that is the neurons at that vertebral level are fine. And so the reflex arc is the only signal to that motor neuron is a contracted muscle, which means there's no inhibition, which means hyperreflexia. The Babinski, upgoing toes, is a sign of upper motor neuron damage. It is a sign that there has been demyelination. Babies have upgoing toes because they've not yet fully myelinated their corticospinal tract. And so if you have upgoing toes on the Babinski, you can assure an adult that there's a lesion of the corticospinal tract. The reason why it says plus minus upgoing toes is because if at the level of the lesion the tract is not also taken, there may be completely normal findings down the toes. Above the lesion, normal. On the other side of the lesion, normal. At the lesion, lower motor neuron symptoms. Below the lesion, upper motor neuron symptoms. All right, so this was movement, motor. Motor cortex, precentral gyrus, frontal lobe. It is the primary output of all of the processing that the frontal lobe does in terms of movement. I'm going to talk more about that as we move on. But from this lesson, all we cared about were those pyramidal neurons depolarizing and sending their action potential down the tract. They are multipolar neurons, and they're the final output. These neurons are in the gray matter of frontal cortex. The most lateral are going to manage the most superior structures, face, hands. The lateral in the brain is going to reverse down the tract. The MCA irrigates hand, face. The ACA perfuses leg, foot, and there's a watershed area in between. Frontal lobe does more stuff. Don't want to engage this though, because we're talking about primary motor cortex. The big thing to be able to do is this and this. If you comprehend where things are within the tract, it becomes very easy to deduce the problem. I personally use face to feet, right? Face to feet. Face to feet in the brain was lateral to medial. That twist change happens immediately in the internal capsule. So it means that medial, face, lateral foot. What's more accurate is cervical medial, sacral lateral. However you do it, stick with one. They maintain that arrangement even though they cross the medulla. They're still going to be medial, face, lateral foot, medial cervical, lateral sacral. They will descend and get smaller as neurons leave, leaving behind a tiny sacral vertebral cord, most likely already tapering to the cone medullaris. The crisscross and the orientation are critical to understanding the lesions that come later. The cord looks a little different, and then the lesions you're looking for is the inability to move the muscle, weakness. Whenever you find that, you must then define, is the weakness you found a lower motor neuron problem or an upper motor neuron problem? And you keep assessing up the tract until you find normal, because below the lesion is going to be affected. Above the lesion won't. That's motor systems.